standards that we are proud to uphold in our clinical ethics program here at Michigan Medicine Today. On a personal note, I met Dr. Fiester several years ago, give or take a decade, as my professor in the Masters of Bioethics program at Penn, where she taught conceptual foundations of bioethics. And I think that what Dr. Fiester has meant to my career is best summed up by the evaluation for that course that I wrote her all those years ago, which I remember because I had never written those words before and have never again since, which is that Dr. Fiester was simply the single best teacher I had ever had. So, without further ado, it is my great privilege to share her with all of you. Welcome, Dr. Fiester.
Okay, give me 2 seconds here to hook this up. Right. Got a very tight clamp here. All right, very good. Get my clicker, and I'm coming up. I'm so short that I feel even shorter down there. So I'm going to find myself a spot that I can see you and you can see me. And, oh, look, you are seeing me. Can you see this and me at the same time? All right. If I fall down, there's a lot of doctors here, so I'll be all right. Okay, so here we go. I'm going to talk about the difficult patient. I've got those in quotes. And my task today is to see if I can get the difficult patient reimagined, reconceived, differently defined. Because as we currently define the difficult patient, there isn't a lot we can do about it. So your clinical life, your life as ethicist goes on in much the same way as it always has when we use traditional definitions and understandings of the difficult patient. If we reconceive the patient, if we look in a different lens, I think there's actually quite a bit we can do to improve clinical interactions for those challenging cases. That was not the clicker. Try that guy? No. All right, try this. No. Do you? How about somebody show me which button it is, and then we'll see if my plan of being this far out will work. That's my laser. That turned us off, so we're done. All right, who was the excellent person? Oh, he's running. He's sorry now. First, I made him turn the lights off. Oh, wait. Is that you, Kate?
You might actually have to.
All right, we're going to see if I do. We're going to see if I do. Do I have to be close? Shouldn't have to be. Here's some pieces, by the way, that on which this is based. There are others, but those are two. Okay, how close do you have to be? Is it this guy right here? All right, I can at least be here, so here I am. All right, let me give you an overview of what we're going to talk about. Between 15 and 60% of patients are considered difficult by their treating clinician. On the high end, that's a very high number. The prevalent view of the difficult patient is that these challenging clinical encounters are caused by a patient pathology, something that's wrong with the patient, either something wrong with that patient's character or something wrong with that person's mental status. But my view is going to be that behaviors that get labeled as difficult are actually responses when patients are feeling like they're having problematic interactions with the medical, with healthcare delivery, that there's some type of negative experience that is prompting their reaction, which doesn't mean it's anyone's fault. We can talk about that in the Q&A. But I want to focus just on what the patient is experiencing and why I believe that these difficult behaviors that are getting exhibited are actually reactive. And I want to see what we can do about it. The difficult patient, I'm going to argue, is reacting to a perception. Again, perception isn't reality, but a perception of ill treatment or feeling morally wronged or feeling affronted. So I'm going to argue that the solution, and actually our obligation in clinical encounters, is to try to figure out skills that mediators use that you might be able to employ to be able to address those grievances, real or perceived. All right, so let's talk first about the conventional view of the difficult patient. That research defines the problem exclusively from the perspective of the clinician. And of course it would, because it's in the clinical literature and it's trying to manage the problem for providers, nurses, and physicians. And it actually gets defined, the difficult patient actually gets defined as, interestingly, those who raise negative feelings within the provider. So do you see how it's very provider-centric? It's how do you, Crazy Autumn, affect me, right, as the clinician? And the cause that's often attributed is psychological problems that Autumn has. There's something up with Autumn. And sometimes it's the literature even goes so far as to say that Autumn has a psychiatric disorder. And Autumn, who can be a difficult patient, denies any psychiatric diagnosis, at least that I'm aware of. So what I'm going to argue instead is that it is, I'm going to at least say often, I'm going to say most or almost all, but let's just go with often the case, that what is deemed a mental illness or a characterological flaw or some type of psychological pathology is really a kind of normal reaction, but expressed maladaptively. So that when people are ill, when they're stressed, when they're frustrated by the situation, the circumstance of being ill, and being intersecting with a system that is very large and has all kinds, very multifaceted, it's not surprising that we would have challenging interpersonal interactions. That's my take. Let's look at some of the claims that have been made in the literature just to get a stage setting for how the difficult patient is often thought about in the literature. One study said that difficult patients are those with significant psychopathologic disorders, and that's the root cause, one of the well-known researchers in the difficult patient, Han. And this researcher found that there are predictors of who is going to be considered difficult in a clinical encounter. And it turns out that it's going to be patients who have one of 5 symptoms: stomach pain, fainting, sleep problems, loose stools, and palpitations, which covers, at least in medicine, in internal medicine, a lot of patients. So when you have one of these 5 symptoms, you're more likely to be deemed difficult by your treating clinician. Why? Well, when the physicians were asked, they said it's because patients with these kind of ailments are time-consuming and manipulative. So the hypothesis from the person who ran the study was that what the real cause is that patients with these kind of symptoms provoke frustration in the physicians who are treating them because they are very challenging medical symptoms to manage clinically. And I think that there's some plausibility to that claim. The study, the PI argued that physicians may label patients difficult because of the physician's own concerns about how to properly diagnose or manage or solve the problems that patients with this cluster of symptoms comes with. But I have a different conclusion. I think that's not a bad conclusion, but I'm going to argue that actually this, at the very least, patient's pathology, patient psychopathology is not going to be a good explanation for what is going wrong in those encounters. And I'm going to offer a different explanation for how we get patients labeled, why we find these encounters to be so challenging. To do that, I want to look at what behaviors are considered difficult. So from 2 different studies, I'm going to list how physicians define what kinds of behaviors are difficult. Patients who make repeated visits without apparent medical benefit, they get labeled as difficult. Patients who don't seem to want to get well get labeled as difficult. Patients who engage in power struggles, patients who focus on issues seemingly unrelated to medical care. That's what Haas found gets someone the label of difficult. And then Knisper in 2007 found that patients get deemed difficult if they are demanding, disruptive, attention-seeking, annoying, and manipulative. So I'm going to take those behaviors and I'm going to up the ante on them. I'm going to look at behaviors that are even more problematic. I'm going to focus on the worst manifestations of patient behavior that would get deemed difficult. And I'm going to look at people who are raising their voice or shouting, using foul language, making accusatory remarks or being insulting, making racial or ethnic slurs, or using some type of sexist or homophobic or anti-Semitic language. Because if I can show why those patients are acting the way that they are acting with this very maladaptive, disruptive behavior, then I'm going to argue that these lower level kinds of behavior will conform to that same kind of explanation. If I can do you some good, in other words, with this worst set of difficult, then I probably have already helped you with the lower set. Okay, so my claim is those behaviors that I just listed, they are incontrovertibly inappropriate behaviors in the clinic. And I know that you see those kind of behaviors in the clinic. But I'm going to argue that there's a more compelling explanation than patient pathology. And if I can attack one set of the worst behavior, then I think I've got some help for you for those lower levels. Okay, to do that, I want to introduce to you the case of Fred. I inherited this case and I built this work around patients like Fred, but Fred is definitely going to be in that worst case scenario. So let's read this case. Fred is a 16-year-old with an incomplete C4 injury to his spinal cord as the result of a gunshot wound. He's currently unable to move his arms or legs, though he does have sensation in his lower extremities. Before his injury, Fred attended school intermittently and was on probation for heroin possession. Fred was admitted to an inpatient rehabilitation unit after 2 weeks in acute care. His mother is unable to visit during the week because of her work schedule, and the patient's only other living relative is an elderly grandmother who's homebound. Since he has come to the rehab hospital, Fred has been verbally abusive to staff, frequently using racial slurs. His cursing, often loud, distresses the other patients, as well as the physicians and other staff. Fred often complains of pain and screams loudly when moved, though his physicians insist he's on the highest dose of narcotics that they feel comfortable prescribing. Because of Fred's language and derogatory comments, both physicians and nurses are starting to refuse to work with him. So Fred is difficult. What makes Fred act this way? That's our central question. Instead of focusing on the clinical side, the staff side, the medical provider side of how does it feel to be on the receiving end of Fred's behavior, which is how this case is written, let's focus instead on Fred's perspective. Let's look at the situation from being inside with Fred. Well, Fred is angry. The core problem, I'm going to argue, with difficult patients is they're angry. Who are they angry at? Well, that's what we've got to try to solve. But they are angry. I'm going to argue difficult patients, when you're encountering them, have some source of anger. And the key is to figure out what is that source. I wrote a paper where I articulated 7 maxims that mediators could offer providers to help them navigate patients and difficult interpersonal relationships. And I called these the 7 maxims because it seemed to me I could encapsulate a lot of little nuggets for you all in these 7 claims. But I'm going to focus today on claim number 2. Here we go. Anger is a reactive emotion. So the key is finding its source. Fred is displaying anger. Anger's reactive. So if you want to solve the problem, you want to think about what is the source that is making Fred react that way. So I want us, as a little exercise, see how much participant we can get here. I want us to revisit this case, but now from Fred's perspective. I don't want you to be you looking at Fred. I want you to try to be Fred. I want you to try to feel what is it like to be in this situation. And let's remind ourselves that from the inside, you will not say of yourself that you've got a psychopathology. You will not say that you're unjustified. You will not say that you are an evil person. From the inside, you will look at the situation quite differently. In fact, one of the secrets of mediation is to try to get the view from the inside. So I want you to give me that view now. Why would Fred be angry? if you were Fred, can you imagine grounds? Now, this case is written from a staff perspective, so we don't have Fred's perspective here. We have to build it. But I want you to tell me, if you were Fred, what could be happening such that you would be angry. And I don't want to spend a lot of time on it, but I want you to now volunteer for me. Why might you be angry, given what are perceived as the facts of the case? Yep. Because you're in pain, and it's not being solved. As you understand it, not only are you in pain, but they're not doing anything about it. I can't move my arms or legs, so being absolutely helpless and immobile is already making me angry and frustrated. I'm what? I'm lonely. I'm lonely, and I'm not getting, my mom can't come, my grandmother can't come, I'm lonely, and what are they doing? Is anybody doing anything about it? I got shot. The other guy didn't get shot. I got shot. I had a life, and now I don't have that life. Okay, good. I am trapped in this place. No one should be here that's my age. No one should be here at all. And this is the place I'm trapped in. Okay, now a lot of the things that you're telling me are the circumstances that would absolutely make me angry. Now, refocus a little bit on what do you think his experience might be like? Not here, of course, in the University of Michigan, because this is the leader and the best, but in a typical place. What might you be experiencing if you're Fred? So I'm going to tell you, Fred is African American, and he is in a predominantly, so he's a minority inside this hospital. So I want you to now tell me, what might Fred be experiencing? Perception, not reality. What do you think he's experiencing? Yeah, they're not. All right, they're racially insensitive. They're not helping me. They think it's my fault that I got shot. They don't know what their thought is. I was doing the wrong thing. They don't know anything about why I got shot. Oh, but they've got a whole view of why I got shot. I was in a gang. I'm a drug dealer. Right. What else? What? But now that's not. Do you think Fred would? So Fred's treatment. Yeah, that's what they're thinking. Yeah, they're thinking I'm a total loser. I'm not worth their time. The guy Mike in the bed next to me, he's from Princeton. He was on a skiing accident. He's already got his early decision from Penn. Do you think that they treat Mike the way they treat me? Do you think he thinks they treat white Mike who's going to Penn, who lives in Princeton, the way they treat me? Do you think Fred thinks that? Probably not, right? So what does Fred think? Give me some more, and then we're going to move on. Why am I angry about it? I have to share a room with Mike. What do I see? What do you think Fred perceives in the interactions between the staff and Mike and the staff and him? What? He doesn't get the same treatment. Misunderstandings, what else? And microaggressions. Exactly. I watch them not make eye contact with me the way they make with him. Okay, you are on top of this. Here we go. All right. So, what is Fred's experience on a daily basis? How often does he feel patronized, dismissed, demeaned, humiliated, stereotyped? These are well-meaning clinicians and staff members. That's absolutely the case. But so are the people who perpetrate microaggressions. Nobody's, the whole mess that we're in interpersonally, it's subtle. It's often subtle. Okay, sometimes it's not. All right, whoa, she keeps turning the thing off. All right, how many indignities has he been subjected to in his stay? For example, what if some well-meaning person comes into the room and says, should we change that diaper, Fred? It's meant as a joke, but it doesn't feel like a joke, does it? When you're the 16-year-old who's got burgeoning sexuality and is now wetting and eliminating in a diaper, it's not funny. Does he feel powerless and emasculated from the injury or the treatment they're giving for it? Does he feel heard? Does he feel validated? Does he feel respected? Does he believe that his care team are treating him as well as they treat other patients? And does he sincerely believe that their view of him is prejudiced by his past truancy and heroin use? Does he feel victim to being branded drug-seeking, gang member, high school dropout, or junkie? Because any of those things would make any one of us, without psychopathology, very angry. Does he actually think that the team cares about him? Do they? Because here's the problem. We get compassion fatigue. You know, when you've been dealing with somebody who's difficult, who's challenging, who thwarts you all the time, you get eroded, you get beaten down. And then at a certain point, you care intellectually, but do you care in your heart? Well, it's very hard. It's even harder. Those of us who are parents, we can get to that point with our kids where we're like, go to bed. You know, like you just can't even access the positive feelings. If that can happen to you in a situation of unconditional love, imagine what can happen with the staff and patient. Okay, so now let's account for Fred's behavior. Does Fred, and look at my word here, feel? I'm not accusing anyone of anything, but I'm asking, does he feel mistreated, misunderstood, or wrong? Well, I think he probably does. And those feelings provoke what philosophers call the moral emotions, a category of emotional response that functions as a radar as we go through the world to detect when we have been affronted, when we've been the receiving end of a moral offense, a wrongdoing, a slight, or a harm. You're driving down 94. All of a sudden, somebody comes in front of you and without a turn signal, and you have to slam on your brakes. And what happens to you? You flare up in indignation, and you say, how dare you? How dare you what? How dare you have possibly put my life in jeopardy? 2 children rely on me, for God's sake. Well, those motions are anger, resentment, and indignation. Before you can even analyze what is the source that has triggered those things, and you can feel them for yourself, or when you watch injustice or offense or affront or threat happen to someone else. Before you can even cognitively analyze what has happened, you have already been flooded with that emotion. It's a primal way of our being able to protect our physical and our existential personhood, you know, the threat to oneself. Back to accounting for Fred's behavior. People who feel indignation, resentment, and anger are susceptible to manifesting their moral grievance in counterproductive ways. I was on the phone this morning. Autumn, who thinks she doesn't have a psychopathology, was on the phone this morning right before Kate picked me up. And I was talking to a bureaucrat at Penn who was blocking me from doing something that was going to salvage a student who is an OB-GYN from an African country, who came here on asylum because of being tortured, who was able to get a green card despite the fact that we never grant asylum in this country, so you know it had to be bad. And I'm asking for one small, generous read of the rules, and the answer was no. And I flared up with indignation knowing this man's backstory. Was I as polite as I might have been? Probably I was slightly counterproductive in my interaction and response. Because when people feel indignation, resentment, and anger, they are susceptible to having their voice just a little bit louder, to using words that perhaps you can't use in this auditorium, to having a tone of perhaps a little bit snide and short-tempered. Now, Fred's way beyond that. Okay, I get that. But my claim, the difficult patient, I'm going to argue, is someone who's reacting inappropriately given our social decorum to, again, the perception that one of their interests is being thwarted, negated, dismissed, or ignored. Okay, but you're going to say, but no, wait a minute. He was angry before he stepped foot in our rehab hospital for all the reasons that you started with, right? And you gave me good reasons. It is colossally unfair that this has happened to him. It is horrible that he's in this situation. So you're going to say to me, he was just already mad. He was already beyond any kind of redemption. He was so angry about his situation. So what came first? His bad behavior or the perception that he was being treated badly? In other words, he started treating us like crap from the minute he got here. All right, I hear that objection. Let's assume he did treat the staff badly from the minute he was in the intake, from the minute he got admitted here, because I think it's plausible. And let's say that it isn't anything that happened in this medical establishment or the acute care hospital. Let's say nothing bad happened there. No microaggressions, no darting eyes, no whispering in the hall, nothing. Perfect, absolutely ideal. It's just from this horrific situation he finds himself in. Okay, say it is. But what reactions did he get from that bad behavior? Because here's the problem with bad behavior. Bad behavior begets bad reaction, right? That's what we do with children. They behave badly, we yell at them. Do they suddenly start behaving well? No, they behave worse, especially some of you don't have kids old enough. Once you've got teenagers, they behave badly, you yell at them, and then they behave worse, right? Then they slam the door, say, I'm not talking to you. Slam the door, they stop, right? They don't just say, oh, you're right, mother. I don't know why I used that tone. So what reaction did he get? Just say he was amped up. What reaction did he get? Did he get soothing, compassionate, understanding, arms out? How do we help? And were there any stereotypes or bias that were lying underneath? Because here's the thing, you might have gone in and said, is there anything I can get you, Fred? But did you say it the same way that you said to Mike? So how can I get you anything? Do you need anything? Those small differences are actually picked up by human beings. We're bloodhounds for it. We can pick up subtle differences. So were there any stereotypes or bias that were lying underneath the attitudes or the perceptions of the current caregivers? Because if I perceive any of that, even if you said something quite cordial to me, can I get you anything? It's very different than, how are you doing? How's your family? I saw that your mom was here. Those are differences, even though the one isn't bad staff behavior, but it's different. So was he the victim of any of those kind of treatment? Did they offer him any support? Fred, we need what we want to help. What can we offer you? We have a this, we have a that. What did they offer? Or was it that people were just backing off from him from the very beginning? Remember, I'm assuming that he came in screaming and yelling and using bad words. Did they reassure him that his mental, his spiritual, his emotional, and his physical well-being would be safeguarded with them? You are safe and cared for here. Did they address his grievances? So I'm going to argue that if difficult patients perceive themselves to have been wronged at any level, from the intake person to the receptionist to orderlies to nurses' aides to nurses and medical students and physicians and the whole insurance people who are trying to get the bill paid, the entire medical system, if they perceive themselves to be wronged, then I'm going to argue the ethical obligation, not just the solution to make your life better, and it will make your life better, but the ethical obligation is to address, to validate, repair, and assist in making amends. And that duty to reach out and solve the source of the anger exists in my argument, even if that ethical harm is perceived rather than real. So, where have we been? And then I want to get plenty of time for your questions. The prevalent view of the difficult patient is that difficult behavior stems from something wrong with me. And to a certain extent, let's look at Fred, it might be true. Fred might be angry from all the reasons you talked about before you ever meet him. That's absolutely can be the case. Things have already gone wrong for me, yes. But if you have done the best possible work of righting those wrongs, of trying to convey to me that you are trying to serve my needs, my interests, it is very unlikely that you would have someone who would treat everyone with equal abhorrence. In other words, when I see somebody genuinely trying to help me, I separate that person out from the crowd and I say, they're all trash, but she's actually trying to help me. The fact that it's a blanket difficult encounter with everyone that Fred is encountering makes me suspicious of those claims. And I am suspicious of those claims, just like I'm suspicious of claims that we didn't do anything. We were so perfect, because we're not perfect. And our interpersonal reactions with individuals, they are not perfect. But all right, let's assume, the argument is that these behaviors, that Fred's behaviors are that they are unprovoked, that there's something wrong with me, Fred, my character, and my mental status. But actually, I'm going to argue, I have argued, that they're just a maladaptive response to what I perceive in the world. And if you then think in this system, if you then think in this causal mechanism, then what you're going to try to do is figure out, what did I perceive? What did I experience? And what could you do about it? I've argued that the difficult patient feels wrong and affronted, and so our obligation then is to understand and address those grievances. That I think what we need to do is refocus not on the effect, but on the cause of why people are difficult in these challenging encounters. All right, let me hear from you. Silence. Go ahead. You do not speak for the crowd. I'm just kidding. So at 2 o'clock, I'm going to give a workshop on sort of de-escalating conflict. So I don't want to sort of spill the beans there. You know, some of you are going to be the same people. But what I will say, so let me just say a couple things that I won't repeat there. No, I have to say it. When you're trying to manage a difficult clinical encounter, you have to try to leave your own ego out of it. You have to try to leave yourself out of it. So look at the phrase, it's very well meant. I can't fix this. I can't fix this, Fred, means I am the protagonist here. It's all about me. I can't do it. I didn't do it. I can't solve it. I didn't cause it. That all puts the focus. If you had, if this spotlight were back, it would be focusing on me as the provider, as the nurse or the physician. But that's the wrong focus. It gets us all. It's not that it's not well meant. It's not that it's not heartfelt, and it's not that it isn't true. It's that it takes the focus off of Fred, and it's Fred who needs our attention. So let's just, you and I will grant, you can't fix it. You and I will agree you didn't do it. But with Fred, he doesn't want to hear it. Just imagine that you are amped up, your fists are clenched, you are amped up with rage. And then I say to you, let's just agree I can't do anything for you. Do you feel that? Here's the thing. The only people Fred has to fix this are you. Now, some of it you have to say to yourself, you've got the ego strength. You say to yourself, oh God, there are things I can't fix here. I cannot make him walk. Say it to yourself. But to Fred, what you say is, I want to do everything I can do. I want to get every resource. I want to tackle everything that is humanly possible. Because there are some things that aren't humanly possible that I didn't do and I can't say. Leave that. Just that's in your head. We got that. But when you're talking to Fred, what can you do? So let me give you a concrete example of what was done there. The reason that they called me in to troubleshoot this case was that, every time it's time for physical therapy, Fred balks. He doesn't want to do any physical therapy. We come into his room at 6:45 in the morning and we are ready to help Fred, and he does not want to get going and do his physical therapy. Okay, I don't know, because I've got a 14-year-old, and he goes to a fancy school, and it's all for his, future, and he loves his school, whatever. 6:45, you cannot believe the sass I get out of that kid at 6:45 to try to get him to school. And he's able-bodied and successful and all the rest of it, right? No one wants to get up at 6. Like, so you couldn't trade Fred's morning slot for somebody who was already up since 4 because they can't sleep, they're seniors, and you can't. Well, that is just what we do. I mean, I'm sorry we get it. Everybody likes to say no. If you have figured out every grievance that is humanly possible and you've tried to turn no into yes, because I want to hear yes. I want to hear yes and yes and yes. That's why I got so mad on the phone today. I don't want to hear no. I want to hear we're going to say yes. We're going to find a way. If everything has been done, every interaction has been looked at, every schedule has been changed, then we can say, I just want to express to you, Fred, I'm so sad that I can't solve some of the problems that we're talking about. After you have tried again, don't take no for an answer, just like I didn't this morning in my surliness. That's what I'd say. And a long answer, I'm sorry. I don't know if you had your hand up. I'll go yes, you do. Good. Okay. Good. Yeah, and I think that they're probably more common, thank goodness, than this full out. So what I like to say to people is that I like to use this image. There are fires that can be put out with fire extinguishers, and then there are rooms that are ablaze, and you need a firefighter, not a fire extinguisher. I gave you the room engulfed firefighter, and you're saying, yeah, but mostly we've got sort of the fire extinguisher issues, and I think that's exactly right. Simple de-escalation techniques, the stuff that, for example, I'm going to start teaching at 2 o'clock, simple techniques of trying to mine, M-I-N-E, like or search like an anthropologist for the frustration, and then looking and articulating what that patient's frustration is and trying to hone in on it, and then talk and then validate and then try to problem solve is what you would do in a fire extinguisher situation. So Autumn, I know this is your third visit for these bowel issues. We've run a bunch of tests and they haven't come back. I can imagine how frustrating it is because your symptoms are real. They are altering the way that you live your life. I want us to we're going to stay the course, Autumn. I'm with you here. But it is sometimes the case that these kind of ailments are hard to pin down. I want a solution immediately. You want a solution immediately, and it's eluding us. And that is so frustrating. And I'm so sorry that we're not able to nail it down yet, but we're going to stay the course. We're going to work together. We're going to think, what other kinds of approaches can we use? That's the kind of thing, which again, there's many methods to do that. But you're right, most of them are in that kind of vein. But how often is it that we think all that gets said? I went on and on, right? I must have talked there for, 40 seconds? Most of us think, well, I did that. I would like to be in the room, and I'd like to see if you're actually doing it, because we often think that we're doing more of this than we're actually doing, because our heart's in the right place, and this is what we want to do, but we're actually not doing it. Because I do this exercise that I'm going to do at 2 o'clock, where I will model giving you a complaint, and then you'll model back for me trying to articulate what I'm saying. Inevitably, people think it's one sentence and done, one and done. And there's no way you can de-escalate somebody with a one and done. Let's imagine that I have come to you this is my perspective. I've been here 3 damn times, for God's sake. Do you have a degree or you don't? Right? And then you say to me, we're going to stay the course, Autumn. I'm like, oh, you're going to stay the course? I've been here. It takes, think about it like a solve, like those old commercials for Pepto-Bismol. How you watch the Pepto-Bismol go down the esophagus. Soothe, 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 soothe. That's 5-10 sentences where you get deeper and deeper into your articulation of what the person's tried. Before you give up, from every one of you as your homework, I need 10 sentences, not one. Like I have this one where I've been waiting for my appointment. It's classic in medicine, right? I've been waiting an hour for the appointment. What somebody wants to do, and I'm mad because you have no idea what's on my plate, right? You do, because it's on your plate too, right? But that's how I'm feeling. And you walk in and you say, I'm so sorry that you've been waiting. You gave me 3 seconds of soothe for the hour I just spent waiting for you. It won't do. So my suggestion to you is say it again, say it deeper, deeper, as you watch me get lowered. What you don't want to do is what I call flash escalation, nugget number 3. What you don't want to do is say, well, I could continue here with 10 more sentences, or should we just get on with it? Right? Nothing will be worse than that. So at the very least, don't make it worse. Right. So it depends on what I'm trying to say, and that's part of what we got to do is figure out what is my grievance. So if my grievance is I don't think you tried hard enough. Sounds like that's not the case, and you address that. If my grievance is, I can't live like this, then you articulate that back. It sounds like this is really altering your life. Let's talk about when you take the Imodium. Let's talk about us getting you on a schedule. Let's talk about, or let's say it's, I want an answer, and then you're addressing that. So that's my grievance. I want an answer, and you're saying, here's the thing. When people say I want an answer, sometimes they're worried that there's something really bad going on. And I want to tell you, there's nothing bad going on. You don't have cancer. You're not dying. This is a lifestyle problem, and I don't want to minimize that. But I first want to just say to you, and I want to say it 100 times, you don't have cancer. You are fine. You don't have cancer. I want to say it again. You are fine. You don't have cancer. Find out what the issue is. And then you just give those 5 to 10, because the thing is, if you talk to me the way you talked to me just now, I can't imagine being angry with you, because you're laying it out there. You're not pretending like, well, we're University of Michigan, we get to the cause of everything. You're like, sometimes medicine, we have a fancy word for it. It's called, I know, and now I'm gonna, I know, right? And now I'm gonna say 1,000 times, you are fine. But let's talk about how, let's say I want to cure you, then use the big word. We have a fancy word for it, in fact, idiopathic. It's a terrible word, because it sounds so fancy, and it means nothing. It means I don't friggin' know. I don't know, and you can't believe how often we don't know. And I'm telling you, Mr. Jones, I don't know, but I can also tell you I'm not worried. If it were me, I wouldn't be worried. And if it were my mom, I wouldn't be worried. If it were my kid, I wouldn't be worried. Yeah. I see. Right. So I think sometimes, so these solutions are assuming rationality. And when you're high, your reasoning function isn't functioning. So then I would, something to try. I don't have a panacea. It's idiopathic. I don't, what I would suggest you try, though, is using your voice to be soothing. And it doesn't probably matter what the words are. So, blah, 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 blah. Because it doesn't actually matter. If you're not rational, then it's not the words, but you can hear and be sincere about it. You can convey, even through all that, I want to help. I want to help. I want to find the problem, and I want to help. You can't, I don't know how to convey to you my heartfelt desire to help. I just really want to help. I really want to help. I wonder if I can help. Right? So that's what I would try to do. I like the water, because the water is the gesture of that. But now use what you've got, your sort of God-given, abilities to relate to other humans. Use it. So I would probably try to get that person, I'm going to be here. We're going to figure it out. We're going to work together. We're going to get to a place where we can start to talk. And, it doesn't matter what you say. I would try that in addition to the water. That's perfect. I love that. And I call that writing is validation. I've written about that. That's very powerful. It's like the water. I want to see if you need something. Can I get you some water? The writing it down as validation is another human connection of what you're saying matters to me. It matters so much, I'm going to write it down. I'm going to put it pen to paper. And then it's going to be locked down as valid and important. That's not a small gesture. I agree with you. Right. Okay, so let's look at the first one first. So yeah, I like the what you don't want to do is solve one person's problem by offending, affronting, creating a problem for somebody else. So I like the suggestion of trying to find a slot. And what you're imagining is there's just no one out there who would want a slot that's that early. And then as a mediator, I really don't take no for an answer until somebody's, threatening to fire me or something. So then I would start to say, okay, is it really the case that we have no way that we can double up? And maybe at the end of the year, there's nobody who could come in double on the second shift. There's no staffing that can change. There's just nothing, because that's the way that mediators go to that brainstorming. They start to ask, is there any way? If everybody has said no, is there any way? Well, then in fairness, we might have to say, we're going to have to think about the schedule and maybe for fairness sake, rotate who's at the early slots. I don't know, because I'm not a brainstormer in that circumstance. What I am trying to say, though, is I like the idea of trying to find a willing partner. I like the idea of trying to find if there's any other staffing. And then third, fairness demands that, well, then we have to share those awful spots. That's what we do in a distribution of any scarce resource. We've got to ration it. That we got to ration the 9 o'clock slot. So I don't know, and I'm not telling you what to do. I'm saying the next step is to brainstorm, and you are inside your own system, so you can try to think out of the box for your own system in a way that I can't. That would be my first. At the end of the day, I would not want to have to go to Fred and say the reasonable slots are all taken. They're never going to change. You're always going to be, I wouldn't say it this tone, but I wouldn't want to have to be the one who says to Fred, you know what? You're the one who got shot last, so, you're 6'4". I will do anything and everything to not have to say that. So, but I don't know yet. But I agree with you. It's not so simple. Good. All right. So that's another way. So you're brainstorming. So that might be another way, and you could try that. Now, let's talk about your second one. I have this little phrase that I use with my kids, but also when I teach mediation. I say to them, you always know that, but you don't know what. And I'm going to repeat it. You always know that, you don't always know what. What do I mean by that? You always know that something is happening. You always know that someone has reacted. You always know that when somebody has looked down or rolled their eyes. You know that they've rolled their eyes, but you don't know why. You don't know the what. So I have this all the time, especially with my 15-year-old who's a girl. Anything could happen. I could have a spasm in my back and go like this, and she'll think it was about her. Right? Everything's about her, right? So I say, Talia, you always know that. I've just grimaced. You don't know why. You don't know what. So let's imagine that with Fred, Fred knows that you treat Mike differently, but he doesn't know why. And why does he think? Because you're racist, because you judge him, because you don't like him, because he's more challenging in terms of his clinical picture. And maybe that's not why. Maybe it's that you have a relationship with Mike. So then you walk in and you say, Fred, one of the things that I'm wondering about is, you might see the staff interacting with your roommate, and it might feel different the way that we're interacting with you. One of the reasons is because, one of the things I want to do is build a relationship with you, because we already have a relationship with Mike because he's been here longer, but we haven't been able to build that relationship with you. And I want us to try, so I want to figure out, what can we do? What do you need? What type of interactions? I don't know what to do, because I don't know Fred. But you would be announcing, you know that, you've seen a difference. But it's easy to conclude why. But I want to say that one of the things we need to do, Fred, is build that relationship with you. We need a rapport. We need to know a little bit more about you. What do you need? What do you like? And what would make it better? Build that relationship. Announce that he can see that, but not what. That's what I would try. Looks like I got 4 minutes. Yes. 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 But you know what? It doesn't matter that you don't say it out loud. You've already said it. and you're human. And so what you're pointing to is I could do a whole other presentation just on that, because you're human, I'm human. So I have offended you because I've accused you of making me wait, but you're the one who is the victim of somebody else holding you up. So you feel like, are you kidding me? I've been affronted. You think you're, and then you say, and it's true, you would never say that to a patient, but the problem is, I'm a bloodhound, so I know that. I don't know what, I know that. So I'm already reading your reaction to my reaction and getting offended by it. So I'm not only offended that you were late and you're offended that I'm offended by you're late, but I'm offended by the fact that you're offended that I'm late. I want to go home. Okay, exactly. Right, this is perfect. So classic. Okay, and it's classic human. It's just human. I wish you were coming at 2, because I've got this thing where, and I don't want to give it away, but let me just say this. I deal with this on a daily basis with my home. Because, of course, when you have teenagers, this is the exact reaction. This is the whole interaction, right? Day in, day out. Okay. You have to try, and it's really hard to leave your ego out of it. You have to try. Because if you don't, you are going to set in motion a cycle that will be very hard to get out of. So you can do one of 2 things. Learn how to take your ego out of it, or learn to name when your ego has been involved. You know, I'm sort of myself. I'm kind of, you know, I'd like to explain why. Yeah, it's hard because you don't really want to share a lot of that stuff. So it's really hard to do that second thing, which is to say, the person behind you was late, and we got. It depends on what the circumstance. Let's imagine it's something you can say. You can sometimes say to patients, I am late because the person behind you was late, and you shouldn't have to pay for that. Absolutely shouldn't have to, and that person's late, and the whole system now is off. The whole schedule is off, and it's not fair. So that you could, what I'm trying to do with that second one is give you a way to articulate your humanness without inflaming the situation. It's hard because it's got to be done with finesse. Because what you can't do is say, you think you're mad, you should be me, right? So I mean, that's why I'm dancing here, trying to figure out a way. The first option is the ideal option, and I model it. I'm going to model it this afternoon, where I try to show what would I do if my teenage daughter were doing this, or my teenage son. And I really am trying to teach the skill of leaving your ego out of it. Why? Because it's not about you. That's the thing. It's not about you. And when I'm interacting with my kids, I'm saying to myself, it's just not about me. They're angry. It's about them. When I'm trying to be in the role, let me say this more clearly because I don't want to leave you with something vague. When I'm in the role of problem solver, my role is to solve your problem because I'm in the role of problem solver. They're not my problem solver. I'm their problem solver. So it's true that the problem solvers also have problems, and valid, justified problems. But when you're in that role with the patient who's being difficult, my view is you're in the role of problem solver. When I'm trying to parent an upset teenager, my role is problem solver, not holding up the banner for the way that mothers should be treated everywhere. I am trying to solve the problem. When you're a problem solver, you just rise above that. Think about a negotiator, like a police negotiator. And they're getting sworn at or whatever. What is their job? Their job is to save those hostages and try to get that guy with the gun out of that house without killing himself. Okay, so the fact that I just got sworn at, not the issue. I'm trying to get the people out of the house safe and get that guy out without killing himself so I can arrest him. Right? All right? What he says to me doesn't matter. Just let it roll off, let it roll off, let it roll off. That's a skill, but it's a skill that we would all be happier if we had. I have 30 seconds, I think. Yes, it is. Yes, yeah, yes, yes. It can really help. And that's why the deeper you get into understanding what's wrong with them, the more your justified affront will dissipate. The more you hone in on what that other person's problem is, the more you'll forget about your own. Just like you treat somebody, your back is hurting, but you still had to go to work, so you're still treating that patient, and you're not like, my back. You're like, so tell me about your diarrhea, right? So that's the same skill, and you can do it. So it's been great to be here. Thank you so much for having me.